We will start our first session. The first session will be chaired by Dr. T. Seshasai sir, Professor and HOD, Apollo Medical College, Chittoor. I would like to request sir to come and occupy the chairperson chair. Our first session is, it's a Zoom session. It is an online session. It is live from Ireland. Madam will be on live from Ireland. The next session.
Next, I would like to invite Dr. G. Lata to chair the session. She is undergraduate and postgraduate from SV Medical College, Tirupati. Worked as assistant professor of SV Medical College, Tirupati for 6 years. She did her MCH from Sri Ramchandra Medical College, Chennai from 2013 to 2016. Gold medalist in MD OBG and MCH Reproductive Medicine and Surgery. Underwent training for andrology at Miami University, Miami, USA. She did her fellowship and diploma in minimal access surgery from World Laparoscopy Hospital, Gurgaon. Presented few papers and posters in national conferences. Presently consulted at Sri Ankura Fertility Center, Tirupati.
Zoom. Our first topic is on aneuploidy screening, and the speaker was Dr. Nagaveni ma'am, and she is from Ireland. Madam is a senior most gynecologist, and she had a diploma in advanced obstetric ultrasound, diploma in management for medical doctors, and she is a fellowship of RCOG and RCOG of physicians in Ireland. So we are now connecting with ma'am. Ma'am, login ayyaru.
చెప్పేసావా?
Yes, ma'am, starting.
అది షేర్ స్క్రీన్ రావట్లేదే.
వస్తుంది మేడం. మేడం చెక్ చేయండి మేడం, వస్తుంది ఇప్పుడు. మ్యామ్ మా వాయిస్ వినిపిస్తుందా మేడం? ఓకే మ్యామ్, ఆర్ వి ఆడిబుల్ మ్యామ్?
నాకు వినిపిస్తోంది.
ఎస్ మ్యామ్, యువర్ వాయిస్ ఆల్సో క్లియర్ టు అస్. యువర్ స్క్రీన్ ఆల్సో విజిబుల్ టు అస్.
బ్లాంక్ గా వస్తోంది.
ఎస్ మ్యామ్, వచ్చిందా?
ఓకే, స్టార్ట్ చేయనా?
యూ కెన్ స్టార్ట్ యువర్ ప్రెజెంటేషన్ మ్యామ్, వీఆర్ రెడీ.
Okay. Hello, good morning, everyone. I'm going to start on the topic aneuploidy screening, a necessity or a luxury. Aneuploidy screening means the presence of one or more chromosomes or absence of one or more chromosomes. The common aneuploidies are trisomy 21, 18, and 13, and there are 6 aneuploidies, and many other genetic conditions can happen in the aneuploidy. Aneuploidy is very lethal and the leading cause of pregnancy loss, amounting to 66%. During the first trimester, 50% of the trisomy 21 will end up with the pregnancy loss, and trisomy 18 and 13, 80% loss. The children who were born with aneuploidy will have variable intellectual and physical disability incompatible with life. The aim of our screening is designed to assess a patient at increased risk of having a fetus affected by a genetic disorder, and also to detect the most common aneuploidies compatible with survival beyond embryonic life into viability. It can affect any pregnancy, and all pregnant women should be offered aneuploidy screening. The aim of the screening, the tests we are going to offer should be safe, effective, and accessible to everyone. We start screening including the patient's age and associated risk factors during the first trimester, ultrasound examination, serum screening tests, NT measurement. Advanced fetal medicine scans can include nasal bone assessment, ductus venosus and tricuspid flow, and NIPT. Second trimester serum screening and also involves a detailed ultrasound examination. All these screening tests should follow diagnostic test for confirmation of a positive result by doing amniocentesis, chorionic villus sampling. When we take the age of the mother, the risk of fetal aneuploidy rises with increasing maternal age, and aneuploidies decrease as the pregnancy advances. If you look at the graph here, the pregnancy happening at, if we take the example of 35 years age, it will happen at 1 in 250 at 35. As the pregnancy goes along, 30% loss affects, and then end up with 1 in 350 live births. When you take ultrasound examination into consideration, first trimester sonography is an important and integral part of examination in the first trimester. Many countries offering ultrasonography as a part of routine examination and available free of charge for all pregnant women. It is the most straightforward, non-invasive method to learn about the condition of an unborn child. By assessing like this, the accuracy of detection of aneuploidy will go up to 80% or more when in the hands of experienced fetal medicine scans. Professor Nicolaides have changed the pyramid of antenatal care. The above triangle, the pyramid indicates previously 2 to 3 decades ago, the care was starting at 16 weeks with the first trimester scan. Now he inverting the pyramid of antenatal care to focus on the 11 to 13 weeks assessment. By doing this, we are able to assess maternal history, ultrasound, biophysical, biochemical markers, and it also giving opportunity for recent developments to detect ongoing problems arising during that pregnancy, like preeclampsia, prediction, small for gestational age, macrosomia, diabetes, preterm birth, miscarriages, and stillbirths, and we can have structural fetal anomalies at this stage. Accurate dating of pregnancy is critical to the quality of screening program. A difference of 1 or 2 days gestational age can alter the test result. It can increase the chances of having the problem or decrease. So proper assessment is important, and after 12 weeks head circumference, we also have opportunity to detect the number of fetuses in embryos or fetuses inside twin pregnancy. We can get the idea about the chorionicity. First trimester sonography, detailed evaluation of fetal anatomy is becoming widely recognized as an integral part of first trimester screening. By doing so, we can assess crown rump length, nuchal translucency, face examination, spine, heart, thorax, abdomen, limbs systematically assessed. We can pick up many anomalies at this stage. Coming to the nuchal translucency examination, it is the nuchal translucency have been supposedly due to cardiac failure with underlying cardiac defect, or it can be due to abnormal jugular lymphatic development. So how do we assess the nuchal translucency? It is the ultrasonic marker, fluid collection under the skin behind the fetal neck in the first trimester of pregnancy. The term translucency is used irrespective of whether it is septated or not, whether it is confined to the neck or envelops the whole fetus. The incidence of chromosomal abnormalities is related to the size of the thickness rather than appearance of the NT. During the second trimester, the translucency usually resolves. In few cases, it evolves into either nuchal edema or cystic hygroma, with or without eye drops. Increased thickness of the, as I said, it is the thickness of the, if the NT thickness is increasing, there is a high possibility of trisomy 21 and other chromosomal abnormalities. More than 50 fetal defects, genetic syndromes have been reported with increasing fetal thickness. It may predict the fetal death in the future. We need to, it is very important, however, although it is the high NT can resolve and they can deliver a healthy baby. That is very important to reassure them rather than jumping for intervention. When you look at the first trimester screening and the serum screening test, we have variable tests with variable detection rates. You can see all these. In the first trimester, if you take only maternal age, it's only 30% detection rate. If you take maternal age, NT, only 75-80 with the 5% false positive rate. And maternal age and serum screening, 60 to 70%. If you include maternal age, NT, and then serum screening, the detection rate going up to 95. If you include further all these combined tests, in addition to nasal bone, tricuspid, ductus venosus flow, it is going up to 96. During the second trimester, if somebody missing the first trimester screening, the second trimester involves triple test, quadruple test, and then combined first trimester, second trimester screening. But the detection rate is only up to 94. It is the detection of prenatal screening for Down syndrome has been improving over a period of time and is more valuable with the CF DNA test, which is going up to 99. This is graphically illustrated. So What are the advantages of first trimester screening? It is good time to date pregnancy accurately. You are getting information very early. If there is any issue, mother can have more options. It reduces the number of invasive procedures, may identify other severe anomalies at the time of scan, and we can refer for second trimester detailed ultrasound. NT is a good assessment during the first trimester, even for multiple gestation. It is just if we start at 11 to 12 weeks, CRL, good dating, and then say if the risk assessment is low risk, then they can go on to 20 weeks scan and then follow their pregnancy. If the test result is risk, then they need definitive diagnosis by CVS and amnio. In twin pregnancy, each in dizygotic, monozygotic, there is slight difference. In the dizygotic, each twin has independent risk, whereas monozygotic, each twin has the same risk. cfDNA is good for both tests. And diagnostic tests by amnio CVS, there is a higher possible chance of having pregnancy loss comparative to singleton pregnancy in the both cases. So NIPT, driven the commercial sector as a screening test, it became very attractive alternative to serum screening and is recommended by many professional societies and is in most of the places it's widely available. If you take, most of the people are calling it cell-free fetal DNA, but this test is not detecting the fetal DNA. The DNA is from the cytotrophoblast of the placenta, which after apoptosis enters the maternal circulation. When we are taking the blood sample, 90% of the DNA we detect is maternal in origin. Approximately 10% is from fetal DNA. That means placental. So it is a misnomer. So cell-free DNA would be better. So when we are doing a NIPT test, we need to understand and inform the patient that it is a screening test. It is not a diagnostic test. It has high negative predictive rate. And do we need to think, is it a valuable alternative to combined or quadruple screening? If you look at the detection rate for trisomies, with the trisomy, it is going up to 99. False positive rate is only 0.1%. It is good for trisomy 18 and 13 too. The American Family Association of Physicians have been released key recommendations. In this, cell-free DNA, which is generally performed at 10 weeks, is superior to first and second trimester screening with fewer false positives, and is higher positive predictive values for trisomy 18 and 21. This is the evidence A. So when we are in giving the information for people in an Indian setup, there are decision aids have been studied. In this research article from BMC have been showing it is applicable for low literacy decision making. Decision aid in the form, what are the reasons for screening, why they don't want screening, and what do they understand from screening. By giving this leaflet, they are well able to go through, but it have to be in the local language and applicable to everybody. And 100-dot diagram illustrating the accuracy of the NIPT, so patients can understand easily what are we talking about, 1% false positive rate or missing the cases by dot examination. So whenever we have all the results available, deliver the results in person at a pre-established time. By delay, personally deliver the diagnosis as soon as possible following definitive prenatal testing. Each condition detected with prenatal testing has different outcomes. For more details and support. What people think NIPT test means, it is a simple blood test. But we need to fully understand with the high risk results, there may be other possibilities, surprises may come, like maternal cancers, maternal sex chromosome aneuploidies, and milder fetal phenotypes. ACOG SMFM September 15 have released ethically and patient may choose cfDNA screening but should be counseled regarding its limitations and benefits. And International Society for Prenatal Diagnosis have also said the cfDNA should not be recommended maternal age only as a screening test and NT only. And we should not be offering this test for microdeletion screening. So what are the challenges? That means people expect results low or high risk. Sometimes it depends on the fetal fraction. So for a best performance test, we need 8%. It can be affected by gestational age. That means beyond certain age or below the age, it can be affected. And maternal BMI, type of aneuploidy. With the triploidy, low fetal fraction is possible. In twins, each twin will have a different fetal fraction and increased low-call rate. Sometimes false positives can happen from placental mosaicism, vanishing twin, maternal sex chromosome abnormality, underlying neoplasia, apoptosis of cancer cells, and aneuploidy. When you come to the counseling, giving information, prenatal screening doesn't aim at preventing the birth of people with disabilities in society, but at helping individual pregnant women make important, highly personal reproductive decisions. Advantage being prepared ahead of time for the birth of a child with special needs, respect individual decision, and the program should not express a preference for a certain course of action. So options: when the test is positive, women should choose to have a therapeutic abortion. Be aware of false positive test, false negative test. If it is false positive, you are aborting a normal pregnancy. False negative test, that means probably birthing an abnormal child. So respect and value some women who have strong moral religious objections to abortion. They may think it equals to murder. With the detailed ultrasound examination of the second trimester, we do come across various soft markers. Some are associated with increased risk of aneuploidy, You can see the list of the things here, and some markers may have increased risk of non-chromosomal abnormalities. They come in isolation. And these are fetal pilactasis, single umbilical artery, enlarged cisterna magna. Soft markers of undefined association. Sometimes we may come across isolated clenched fist, rocker bottom feet, sandal gap, strawberry-shaped skull. For a definitive diagnosis, chorionic villus sampling. This can be done through transabdominal, transvaginal route from 11 to 13 weeks. The result is accurate enough, but you will see 3 types of results. It can be normal result, abnormal result, or mixed result in case of mosaic report. This can happen in 2%. There is a procedure-related risk of miscarriage less than 1%, and result will take good 3 weeks. By amnio, we all know the result is again 3 types, but the mosaic possibility is 0.5%. And the risk, the procedure-related risk of miscarriage is less than 1%. This number has been very less nowadays with more expertise and experience with the procedure. It is reported to be less, and result will take 3 weeks. This NIPT has been emerged and becoming the vanguard of genomic medicine now. It became a luxury test in private practices. It means the price may go up to 9,000 to 10,000. People are paying from their pocket. Sometimes it can be covered with partial insurance. So, can we offer this NIPT test with the public funding? It's like an elephant in the room. So, it's not an easy task.
Ma'am,
So,
your time is, ma'am, gentle reminder, ma'am, time is half an hour is over, ma'am. You can rush through your slides, ma'am.
Oh, okay. So, will I stop now, Deepa?
No, ma'am, you can rush through your slides, ma'am. We have to see your full presentation, ma'am. We will see your full presentation, ma'am.
Yeah, this is just, these are the different articles from the Indian experience. They are just saying the knowledge about public-private sector is going up, and then we are offering only 18 to 20 weeks scan, but that is in the low source setting. On regular low volume setting, the detection rate is 56%. If you take fetal medicine centers, the detection rate is 80%. And there is another journal of medical ethics. They are also saying, can we offer this NIPT by payment? That will raise financial barriers, that will not improve informed decision making. Coming to Indian scenario, Indian Medical Journal have been said prenatal screening for genetic disorders, suggesting guideline. This article also highlighting that there is no government program, no guidelines in place, no nationwide consensus regarding screening. There is a lack in awareness and it's a consensus. So is it a necessity or luxury to do aneuploidy screening? When you ask this question, healthcare is an individual necessity and luxury for who can afford it in a private hospital. So WHO have been keep thinking about, can we provide an aneuploidy screening in low-income countries, developing countries. It has been going on for the last 3 decades, and they are highlighting only our negative points. That means age, above 35 population in India is 2 to 5, in USA 8-3. We have infrastructure challenges and also financial limitations, equity of access, and private public insurance is not uniform. It is not existent for everybody. And they also highlighting, unless subsidy programs are developed, this is continued from WHO article. So those who lack access for the services have potential to increase disease burden among less advantaged. So government is aiming to support and provide necessary services for their survival and thrive. So not much of a value. Whereas disability activists, the fewer individuals with the disabilities who are present in the society, the less the society will learn to value such individuals. So again, another article from Southeast Asian countries analyzing private public practice, low income, medium income. They are offering low income countries consider health care as a luxury, and middle income countries, health care is a necessity. Private sector has income elastic in both their economical analysis saying they have a luxury, they can spend money. So Manmohan Singh released this article, you might have, everybody know, every woman, every child by 2030, and stating that India is still a developing country. I hope they are still working on it. And then recent Prime Minister Narendra Modi speech on the Independence Day saying that we will become a developed country by 2047, and so that every citizen will have good health care and education. I hope the promise will continue. So knowledge empowers confident health decisions, and applied screening for pregnant women is a necessity and luxury, where it is proven to be effective and safe for both mother and baby at birth. Thank you.
Thank you, ma'am. That was a very wonderful presentation. So any questions
Thank you.
from the audience? Ma'am, the session is now open for the audience.
Okay.
Good morning, ma'am. Thank you for your excellent presentation. And one more thing is,
Speaking?
hello.
Who's speaking?
This is Dr. Lata, ma'am.
Lata, how are you?
Fine,
Tell
fine,
me.
ma'am. So one more point, like even prior to gestation, can we go for this aneuploidy screening as a part of pre-implantation genetic screening?
The NIPT, you mean, Lata?
Not an IPT, ma'am. In general, aneuploidy screening, like in IVF.
Oh, yeah, pre-genetic implantation.
Pre-genetic.
Yeah, it has been reported, isn't it? They are recommending it, yes, for aneuploidy screening. Did I answer your question, Lata?
Thank you, madam.
Hello.
I am Dr. Seshasai, 1 year junior to you.
Yeah, hello, Seshasai. How are you?
Fine, madam. Very nice presentation and very wide appearance. Everything is good. And in general, hospitals, they're practicing very, very less in India.
Yeah.
So, but they are spending a lot in ultrasound. So we can advise them frequently. So this can be possible. Thank you, madam.
Yeah, it is possible. Yeah.
Yes, madam.
So, but we need to start at one point to streamline services.
For everyone.
It's not an easy thing. Yeah. Thank you, Seshasai.
Thank you, madam.
Thank you.
Any questions from the audience?
Ma'am, good morning, ma'am.
Good morning, yes.
Yeah, this is Dr. Bhuvneshwari, ma'am, assistant professor.
Hi.
Ma'am, what do you think, in your experience, we'll commonly see this isolated echogenic focus in the ventricle.
Yeah.
But they'll give in the scan report, in the absence of other soft tissue markers, it is insignificant.
Yes.
And we are doing this down screening and NIPT, even they are worried, and we are doing even NIPT also, ma'am. So what is your
Yeah.
experience, ma'am, regarding this single ventricle isolated echogenic focus?
Yeah, that if it is isolated one, if I do detailed first trimester scan,
Yes, ma'am.
as I described in the picture, most of the things I do, I look for NT, and then if I don't see any other thing except echogenic focus,
Yes, ma'am.
I don't bother to tell them. I
Okay.
just keep an eye on it and then evaluate second trimester.
Okay, ma'am.
And if anything coming up, then I will be doing NIPT,
Okay, ma'am.
because we don't have serum screening here in Ireland.
Yes, ma'am.
We do only NIPT or referring to fetal medicine if
Oh,
there is something else is happening.
okay, ma'am. Thank you, ma'am.
Yeah. Thanks.
Thank you, ma'am. Thank you so much, because
Thank you.
I
Thank you,
know that its
Deepa.
time is odd for you. It is about 2 o'clock in the morning for the ma'am.
It's okay.
So,
It's
thank
okay.
you, ma'am. Thank you so much, ma'am.
We'll take care of next time. Thank
Ah,
you.
thank you, ma'am.
Thank you.
So I would like to invite our next speaker. The next topic is on ART ovarian stimulation protocols. The speaker is Dr. N. Sanjeeva Reddy sir, and sir is a professor of Department of Reproductive Medicine and Surgery, Sri Ramchandra Institute of Higher Education, Chennai, and sir is the first person to start the first super specialty course, MCH Reproductive Medicine and Surgery. So we will request you to. Thank you, sir. We welcome you, sir.
Good morning. I'm very happy to come to our own college. Today I'm going, and at the same time, I would like to thank Dr. Bharati, Dr. Parthasarathi for inviting me to be here and share some of my thoughts with you all. Today I'm going to speak on ART ovarian stimulation protocols. Controlled ovarian hyperstimulation for IVF. The idea is to produce more multiple follicles so that we will have more number of oocytes so that we can select good embryo for transfer so that we will get very good pregnancy rate. If you do the stimulation, there will be increased estradiol production so that it can lead to 15 to 25% of patient the premature luteinization. This can be avoided by suppressing pituitary gonadotropin production by co-treating with a GnRH analog. A number of advantages is there with this and some disadvantages. Various protocols involving the GnRH analog have been developed to tailor individual requirements. Improvements in protocols for COH have given us a variety of programs from which to choose. Some centers they will use permanent program to achieve the best live birth rates, and most individuals they will go for the individualized stimulation protocols. At the same time, they will take care. We have to take care avoiding OHS and the promotion of patient comfort. There are three important steps are there in controlled ovarian hyperstimulation. In step 1, we have to achieve baseline hormone levels. This can be done by GnRH analogs. The next is step 2. We have to stimulate the ovaries to mature and release multiple follicles. This can be done by giving gonadotropins. And step 3, we have to trigger ovulation and to prepare the uterus for implantation of the embryo. This can be achieved by giving HCG or GnRH antagonists. There are different IVF protocols available. Natural cycle IVF, this was the first we got. Modified natural IVF cycle, mild IVF or minimal stimulation protocol. Finally, the usually used conventional IVF. In natural cycle, we won't use any drugs. But so we don't need for us to give us any luteal support. In modified natural cycle, we may use less dose occasionally. So whenever you are using gonadotropins, then you need to give prevention of LH surge by giving antagonist. And ovulation trigger is needed to by giving HCG. Whenever you are giving hormones, we need luteal support. Mild IVF, some people they thought by giving conventional, we are giving too much of hormones, it can be change the implantation potential of the endometrium. So no need for us to give so much gonadotropin. So they reduce the dose so that they can get. And also the decreased ovarian reserve patients also by giving more amount of gonadotropins, we are not going to get many oocytes, so that they decided they will go for the mild IVF. Here we can use the drugs, oral ovulagens and gonadotropins also in low doses, but we need to give GnRH antagonist to prevent LH surge. At the same time, we can go for either HCG or GnRH agonist for trigger, and always you need luteal support. Conventional IVF, this is the throughout the world most preferred protocol. Here we will be giving high dose of gonadotropins. Always we have to go for either agonist protocol, antagonist protocol to prevent the LH surge, and depending upon whether you want to go for the fresh transfer or not, we can decide either you have to go for the HCG or agonist trigger also we can give. Here the luteal support is always necessary. The common protocol I told you already, this is a conventional stimulation protocol. There are two types. One is agonist protocol, another one is the antagonist protocol. Next is the minimal stimulation protocol. We will discuss each one.